Welcome to this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMEDPRN. And for PRN members, slides can be found under the Library Entries section of the ACCP Communities website.
I'm going to be looking at the effects of intravenous lipid emulsion administration in acute tramadol poisoning. So I just want to preface to say that I do not have anything to disclose or gain from doing this presentation. And the outline for this journal club presentation would include highlighting the tramadol toxicity and the role of intravenous lipid emulsion and its role in tramadol overdose. And then I'll discuss the methods, results, and conclusion of the study, and conclude with a discussion of the strengths and weaknesses of the study and its applicability to clinical practice. So tramadol, which is also known as Ultram, is a synthetic opioid. It has been approved for the management of pain, and it is structurally related to codeine and morphine. It is available here in the United States as an oral formulation in both tablets and liquid form. And the therapeutic doses ranges from 50 milligrams to 100 milligrams orally, taken every 4 to 6 hours with a maximum dose of up to 400 milligrams per day. So when ingested orally, tramadol has a rapid absorption with a 75% bioavailability. Its peak levels is about 1 to 3 hours. And if taken the modified release, of course, is expected to have a longer peak at about 2 to 12 hours. It is very lipophilic and it has a log P value of approximately 2.6. So lipophilicity is denoted by a log P value. And the more positive a log P value is to 1, the more lipophilic an agent is. So with this being 2.6, tramadol has great lipophilicity. It has a volume distribution of about 2 to 3 liters per kg, and it is metabolized in the liver to its active form by the CYP2D6 enzyme to the O-desmethyl tramadol, and then also to the by the CYP3A4 enzyme to N-desmethyl tramadol. It is excreted by the kidneys. For tramadol, it has a dual action, so it exerts its effect on the mu receptors, and it also prevents the reuptake of serotonin and noradrenaline reuptake by here. This causes a downregulation or disinhibition of the pain receptors to help to counteract pain. For tramadol toxicity, the signs and symptoms go from mild to severe, mild being meiosis, drowsiness, tachycardia. In some instances, patients may experience headache, so where they become severe or moderate to the point where they're having difficulty breathing. In some instances, they may develop seizures or respiratory depression. So when using high doses, tramadol can elicit its response to increase in neurotransmitters. And we talked about that it prevents the reuptake. And by preventing the reuptake, it also prolongs the exposure of the neurotransmitter in the postsynaptic membrane. And this is normally done with increasing doses of tramadol. This often leads to an increase in the risk of seizures. And the seizure risk is often seen in approximately about 15 cases of patients and seen in doses greater than 1,600 milligrams per day. But I must pause here to say that even though seizure risk correlates with increase in dosing, seizures have also been seen at doses as little as about 50 milligrams when taken with serotonergic medications such as your fluoxetine, your TCA. This can increases the risk of seizures when taken concomitantly with tramadol. We talked about the peak level of tramadol being about 1 to 3 hours. So the highest risk of seizures is often seen within the first 4 to 6 hours after excessive ingestion. And the presentation of seizures is normally single tonic-clonic episode. And of course, you can have multiple episodes of seizures if left untreated. The management of tramadol toxicity is paramount. It's very important that we are very prompt with our management. And the first line management is going to be supportive care with airway management, CPR for circulation, and in some instances, patient may require fluid resuscitation or oxygen therapy. In addition to that, patients can be administered naloxone if they present to the ED with decreased levels of consciousness or if they're unresponsive. For seizures, the first-line medications to treat seizures are your benzodiazepine, and second-line agents can be your levetiracetam, your phenobarbital, propofol, or general anesthesia if the patient continues to seize. And here I just list some dosing recommendations of the benzodiazepine that you would often use if persons are presenting with seizures after tramadol overdose or ingestion with concomitant serotonergic medications, and the dose here for naloxone. The best combination has been seen with your naloxone diazepam combination, as this has been shown to be more effective when done in animal studies. So what role does intravenous lipid emulsion play in tramadol overdose? So typically we are accustomed to our intravenous lipid emulsions being used primarily in our parenteral nutrition to support patients who are malnourished or who require additional support in their nutrition. But in addition to that, intravenous lipid emulsion has been used as a rescue agent in acute fat-soluble drug poisoning, such as poisoning with calcium channel blockers, overdose with beta blockers, or in cocaine. The precise mechanism of intravenous lipid emulsion is really unknown, but there has been a theory behind how it's able to arrest toxicity of lipophilic medications. And this theory is known as a lipid sink theory. And this theory postulates that with continuous intravenous lipid emulsion, it's able to shift the equilibrium in the body, and medications that are highly lipophilic, like tramadol, is able to, because of its high affinity to the lipid, is hydrophobic, it's going to move from out of the tissues and into that lipid phase that the intravenous lipid emulsion has created. And this creates an era where it's able to be removed from the body. The 2023 American Heart Association guidelines on the management of cardiac arrest or life-threatening toxicity due to poisoning has recommended the use of intravenous lipid emulsion in the reversal of local anesthetics such as ibuprofen at a dose of about 1.5 mil per kg up to 100 mil. So it has been widely used in reversal of many other agents, but not so much with tramadol. Some side effects that one can expect with the use of intravenous lipid emulsion: you can have hypertension, you can have abnormal hepatic function tests. In some instances, patients may develop anemia and also high triglyceride levels. Intravenous lipid emulsion is contraindicated in patients if they have hypersensitivity to egg or soybean, or if they have severe disorders of lipid metabolism, which is characterized by a triglyceride level of greater than 100 milligrams per deciliter. In the event that patient has a triglyceride levels of 400 or more, intravenous lipids can be used, but the dose and rate would have to be modified. So what studies are there to look at the use of intravenous lipid emulsion in tramadol seizures? So there, as I mentioned before, there are not a lot of studies that looked at tramadol overdose with intravenous lipid emulsion as a rescue therapy. Most of these studies that were even conducted were conducted in animals. But there was this one randomized clinical trial that was done in 2021, which was done in Iran. And it looks at the effects of intravenous lipid emulsion on tramadol-induced seizures. The dose that they used was a 12 mil per kg of the intralipid emulsion, and the control group was just standard of care. Their population involved adults 16 years and above who had presented with tramadol ingestion, clinical presentation of tramadol overdose, and referring to the ED within 4 hours of tramadol intake. So from this study, they had noted that seizure occurred in all the patients who were in the control group and none in the intervention group. And the hospital stay was much shorter in patients who had gotten the intravenous lipid emulsion as opposed to standard of care. The study concluded that intravenous lipid emulsion can work as an adjunct to standard antidote protocols in tramadol intoxication and can be used to prevent tramadol induce seizures. However, based on this study, they had quite some limitations. They did not look at patients who were presenting with any decreased levels of consciousness or if they were unresponsive. And the average dose of tramadol that patients presented with that illicit seizure was about 300 milligrams. So not the typical overdose that not the typical dose that we would see for patients who are presenting with tramadol overdose. As mentioned before, that we tend to see tramadol toxicity in doses greater than 1,600 milligrams per day. But of course, seizure can be at any dose as little as 50 milligrams per day, especially if given combination with other medications that can increase serotonin. But for this study, it didn't look at those parameters. So for animal studies, as mentioned, a lot of the studies that were done involve animals, and animal studies have shown that despite benzodiazepine being the first-line agent of choice to really arrest seizures in patients who are taking tramadol, it increases the morbidity and mortality when used. Naloxone, even though, again, this is an agent that has been employed in the acute setting to help with tramadol toxicity, it only partly inhibits the action of tramadol. So tramadol would still be able to go on to elicit its toxic effects if naloxone is used or benzodiazepine is used. So with intravenous lipid emulsions, being that it has shown positive outcomes in reversing anesthetics and cocaine reversal, it's shown to be a great agent to be used in tramadol poisoning. Few case reports and single-blind trials of intravenous lipid emulsion have shown that it has positive outcome when using tramadol toxicity or tramadol poison. So based on that, this study set out to evaluate the short-term effects of intravenous lipid emulsion administration in cases of tramadol poisoning. So this study was published in the Journal of Emergency Medicine in 2023, November 2023. And it was a randomized double-blind placebo-controlled trial, and it was done in a single center in Iran. And for its inclusion criteria, it included patients who were of the age of 16 to 65 years of age, who had a GCS score of less than or equal to 12, which is about a moderate GCS scale. And if they had a positive history of greater than or equal of 400 milligrams of tramadol ingestion and a positive urine test for tramadol only. So when the patients were admitted to the ED, if they had any other positive substance screen, they would have been excluded. So it had to be tramadol tests only. And they excluded patients if they had a high risk of intravenous lipid emulsion reaction, or if they were diagnosed previously with epilepsy or any other condition that could cause seizure that could be a confounder in the study, if they were unable to confirm the ingested doses, and if they improved after giving naloxone. And they gave naloxone for patients who had, if they were presented to unresponsive or if they had decreased levels of consciousness, and they gave a dose of 0.5 every 1 to 2 minutes. Patients were also excluded from the study if they had any renal or hepatic impairment or if they were pregnant. So the primary outcome of this study was to look at the occurrence of seizure at 12 and 24 hours after admission. And the secondary outcomes looked at the difference in the Glasgow Coma score, if there was any increase or decrease after giving the intervention or persons who were using standard of care. They also looked at vitals because, as mentioned before, that intravenous lipids can cause hypertension. So they looked at the vitals at 12 and 24 hours after admission. They looked at the length of stay and the occurrence of adverse events. So this was an event-driven trial. It required an absolute reduction of 25% to reach 80% power. They did not note a sample size to reach power, again, because there is not a lot of data to support the use of intravenous lipid and tramadol, so they didn't have a priori for this study. And the analysis was done using SPSS software to assess primary outcome on the intention to treat population. The level of statistical significance was set at a p-value less than 0.05, and all the other tests were standard analysis. Patients were randomized in a one-to-one fashion with 60 patients in each group. So in the intervention group, patients received 20% of the snuff lipid, and it was given at 100 ml bolus with a max of 250 ml within the following 15 minutes. So if the patient got the bolus and they were still seizing or they still didn't have an improved consciousness, they would get an additional 250 ml within the 15 minutes. In the control group, the patients received 0.9% normal saline. And again, they tried to mimic the same dosage to ensure that the blinding was maintained. So based on their inclusion criteria, 120 patients were eligible for randomization. After randomization, they had 60 patients each in each arm. So they had 60 patients in the intravenous lipid emulsion arm and 60 patients in the saline arm. They noted that they did not have any patients lost to follow-up, and this is quite understandably so because patients were presenting to the ED and it was management within that acute setting. So this table outlined the baseline characteristics of the patients that were included in the study. As you can see, the average age was about 23 in the intervention group, and for the placebo group, it was 27. So they were fairly young individuals. The dose ingested, as highlighted here, it was 2,840 in the intervention group versus 3,397 in the placebo group. And even though it was a difference, it was noted not to be statistically significant. For patients who were presenting with respiratory depression, again, it was much lower in the intervention group as opposed to the control group. And with a p-value of 0.11, it was not statistically significant. Patients in the intervention group had a higher level of consciousness when compared to the placebo group. And for the occurrence of seizure before randomization, you had more patients in the intervention group experiencing seizure when compared to the placebo group. Again, these differences were not statistically significant. And as for the results, so the primary outcome was looking at the occurrence of seizure 12 and 24 hours post-randomization. They also looked at the change in Glasgow Coast score, again at 12 and 24 hours post-randomization. So for the first occurrence of seizure, which was noted at 12 hours after admission, we can see that the patients had an improved of GCS score because initially it was 10 and 9.5, and then we can see where it increased to 12 in the intervention group, and for the placebo group, there was also an increase. And this difference was statistically significant. And then for the 24 hours post-admission, again, there were increase in the GCS score in patients who were in the intervention group and also in the placebo group. And we can see that the trend in which the GCS score increased was about the same. It was from 12 to 14 and then from 10 to 12, so about the same. And again, this difference was statistically significant. In addition to that, just to highlight here that for the vitals, they did increase from the 12 to 24 hours. There was an increase in the patient's SBP and DP, and this increase was statistically significant as well. And then for the occurrence of seizure at 24 hours, 16 patients in the intervention group developed seizure, while for the placebo group, 30 patients of the 60 patients developed seizure. And this was statistically significant. For patients who had seizure despite intervention, it was only 2 in the intervention group, as opposed to 14 patients in the placebo group had a recurrence of seizure. The duration of hospitalization was much lower in the intervention group with a total days of 2, which is much longer in the placebo group. They noted that for rhabdomyolysis, which is a side effect that intravenous lipid emulsion could cause, was only two patients developed that in the intervention group as opposed to 10 in the placebo group. And again, all of these differences were statistically significant, being that the p-values were less than 0.05. So from the summary of the results from the study, rate of seizure occurrence was lower in the intervention group, with 16 persons from the intervention group developing seizure, and 30 of the 60 patients developed seizure in the control group, and this was statistically significant. They had noted that they require an absolute risk reduction of 25% to reach 80% power. The absolute risk reduction from this study was 23%. So technically, they did not meet power. They're near there, but they did not reach power. So compared to the control group, the intravenous lipid emulsion group had a higher level of consciousness after treatment with a GCS score increase, 12 for the intravenous lipid emulsion group versus 10 in the control group, and this was statistically significant. The length of hospitalization, as noted before, was much less in patients who were getting the intravenous lipid emulsion when compared to the placebo group. So the author concluded in the study that short-term benefits of intravenous lipid emulsion in patients with tramadol intoxication and loss of consciousness is beneficial in those patients with tramadol toxicity who were admitted to the emergency department. So now on to the strengths and weaknesses of the study. So overall, it's definitely a breakthrough study in terms of looking at agents that could be used to aid in tramadol toxicity. There is not a lot of data that looked at tramadol toxicity here in the United States. As mentioned before, that this study was done in Iran, and their prevalence for tramadol toxicity was very high. It's about 60%, because tramadol is not only available there in oral formulation, but also in IV formulation, and oftentimes patients who present to their ED not only have tramadol toxicity, but along with cocaine or fentanyl toxicity. But here in the United States, the prevalence is not much. And even looking at the CDC website, they do not delineate between the different synthetic opioids, overdose, or mortality. They combine them. So it's hard to really assess the prevalence of tramadol toxicity here in the United States. But of course, even on the CDC website, they noted that as it relates to synthetic opioids, the agent that really causes the most harm or mortality is fentanyl. So for this study, I feel like it had more weaknesses when compared to strengths. We can start with a positive. So overall, this study was randomized, which increases the internal validity of the study. The inclusion criteria and primary outcomes, I feel they were appropriate. They included persons who only had toxicity to just tramadol only, as opposed to including patients who had toxicity with tramadol plus other substance. So it helps to keep the validity of the study. The primary outcome in looking at seizures, I think that was an important parameter to address, because even though seizures can be seen in lower doses of tramadol, it is increased when they ingest increasing amount of tramadol. So looking at that parameter was very important to assess the efficacy of intravenous lipid emulsion in this study. As it regards to weakness, the baseline characteristics, the differences were not that statistically significant, but looking at the doses of the tramadol, overall dose of the tramadol that was ingested in the intervention group versus the placebo group, it was much less. And I feel like this could somewhat influence the outcome of the study, being that we saw a lot of patients had a lot less recurrence in seizures when in the intervention group when compared to the outcome group. So I feel like that could influence the outcome somewhat. In addition to that, there was no definite measurement of the ingested dose. They talked about asking bystander in terms of how much doses they think the patient ingested. I remember one of their inclusion criteria was looking at patients who ingested more than 300 milligrams of tramadol dosing. So for me, it introduced bias into the study, because they had to rely on persons to tell them the amount of dose they think that the patient ingested. And again, it had to come from bystanders, because most of the patients that presented to the ED had decreased level of consciousness. And even though they tried to ask the patients once they awakened, there were some discrepancy in what the patient reported versus what the bystander reported. So I feel like that introduced a little bit of bias into the study. They noted that the study was randomized and it was blinded, but blinded was somewhat compromised, because the way how they did the blinding, especially with the administration of the medication, they placed a colored sleeve over the medications when they're being administered into the ED. So they placed a green sleeve over the intravenous lipid emulsion, and also over the sodium chloride. But at some point in time, there were issues where that green sleeve fell off. So persons who were recording the occurrence of seizures were able to see what each patient was getting. They mentioned rhabdomyolysis as a possible adverse event to measure, but in the study, they talked about hypertriglyceridemia as a possible side effect from intravenous lipid. They talked about hypertension, but they did not report the occurrence of any of these adverse side effects, only rhabdomyolysis. It was a single center study. It was done again in Iran. So it was hard to generalize the findings from this to the general population in terms of even persons who, in terms of genetic makeup, in terms of race as well, because we do know that genetic makeup play an important role in patients' ability to metabolize tramadol. And we have poor metabolizers who are more at an increased risk of tramadol toxicity when compared to other persons. So they did not delineate the type of patients that make up this population or their race or background. So not knowing that, that's definitely a big limitation for the study, and it would warrant us looking into genetics and how it plays a role in tramadol toxicity and see if intravenous lipid emulsion still could be an agent to utilize in those patient population. In addition to that, the occurrence of seizure was based on bedside observation. So we mentioned before that for seizure that occur in tramadol toxicity is tonic-clonic. So this is very evident, and we can see oftentimes when patients are having tonic-clonic seizure. So this was only recorded based on what the observer saw on the floor. Again, this is definitely a way how bias can be introduced in the study, because based on the fact that the sleeve was unblinded somewhat during the study, they would know which patient was getting what particular intervention or medication. And if they're just recording the seizure based on observation, it potentially could have influenced bias into the study. So can we use intravenous lipid emulsion in our ED to help with tramadol? So definitely, and this was something that the study noted, that more robust studies are needed to make a generalized recommendation in using intravenous lipid emulsion in acute tramadol toxicity. However, I think it could be an option for patients who present with tramadol toxicity of more than 1,600 milligrams or more, with decreased levels of consciousness despite using naloxone and benzodiazepine. So if the patients were able to get supportive care, naloxone with increased dosing, benzodiazepine to treat the seizures, and they're still not able to regain consciousness, or their level of consciousness is not able to be improved, then I would potentially resort to using intravenous lipid emulsion as an agent to help to aid with that tramadol toxicity. And now I welcome any questions, comments, or concerns.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.